Thank you so much, and thanks, Dr. Atella. That was very informative, and you might not expect to hear that coming from an internal medicine person, but the emergency and critical care guy in me enjoyed that. The pictures were phenomenally helpful. But now you're stuck with me again for the final segment of this 3-hour journey through the land of GDV. And it's an important last journey for this disease. The postoperative care is just as important as the preoperative stabilization. It's just as important as the surgical corrective surgery. We want to maximize the chances of these patients getting home to their families and leading the highest possible quality of life. So, as you're preparing them for the operating room, as you're working with them in the surgical theater, you have to start preparing yourself for postoperative complications. You have to start thinking about what could possibly go wrong with my patient in the intensive care unit. Traditionally, we worry about hypotension and dysrhythmias, but we also have to be particularly cognizant about the potential for regurgitation. We want our patients' control of pain to be more than adequate. We want to make sure that things like sodium, potassium, magnesium, and calcium, and of course lactate, are all trending towards normalization or derangements have completely resolved. And we also need to proactively address any abnormalities in a patient's acid-base status. So, as you're working with these patients postoperatively, you are going to be providing some types of intravenous fluid to continue to address any dehydration that your patient may have had preoperatively, to correct any electrolyte derangements, lactate abnormalities, or acid-base disturbances. Nutritional support is very important for any patient in the critical care unit, and unfortunately, at least in my opinion, as a profession, we need to do a lot more in terms of nutritionally supporting postoperative patients, a lot more in supporting critical care patients in terms of their nutritional needs while they are hospitalized in our care. We need to provide multimodal analgesia and proactively and serially monitor their response to the medications that we provide. It is not enough to say, I gave an injection of drug X and Y and walk away. One needs to certainly give multimodal treatment for discomfort, but then have a plan in place to appropriately evaluate your patient's response and be prepared to make adjustments based on how the patient is tolerating the therapies that you've prescribed. And of course, monitoring and supporting cardiovascular function is of profound importance for this type of postoperative patient. Given those goals, I am a very staunch proponent of adhering to Kirby's Rule of 20. Dr. Kirby is a board-certified emergency critical care specialist as well as an internal medicine specialist here in the United States and is a well-respected international speaker. She developed this list of 20 things that one should evaluate or at least think about in patients considered critical or in serious condition. And as you look through this list of 20 things, you might be saying, but a GDV patient doesn't need all of these things addressed. And that is often a very accurate statement. Not every GDV patient do you need to worry about monitoring renal function. What you do need to do is think about renal function. Think about urine output. So to this day, 12 plus years from graduation, I still have this list of Kirby's Rule of 20 on my billboard that's right next to the computer in my office. I always want to be thinking about these 20 things for any hospitalized patient. When I entered clinics as a fourth-year clinical student at Cornell, our chief of critical care handed us this list. That is still the list that sits on that billboard to the right of my computer in my office today. And I would encourage all of you to commit to embracing Kirby's Rule of 20 as you care for your hospitalized patients, particularly those that are in serious condition or critical care. In general, applying Kirby's Rule of 20, I like to monitor vital signs every 4 and minimally every 6 hours while a patient is in the intensive care unit recovering from GDV surgery. Their blood pressure is also monitored minimally every 6 hours. In a non-azotemic patient who can urinate well, but is able to get up and go outside for his or her walks, monitoring urinary output is not necessarily something that is needed, but if you have an azotemic patient or if you have a patient that is recumbent, for patient comfort and patient cleanliness, measuring urine output via an indwelling urinary catheter may be something that is quite helpful. We monitor electrolytes, glucose, validated pain scores, blood gases, PCVs, renal values, quite variably. No one patient is the same, and here I have basically listed some of the minimums that I typically implore. Let's look at glucose for a minute. Am I measuring glucose every hour in every GDV patient? Absolutely not. But if I have a very seriously, critically ill septic patient, I may be monitoring glucose that frequently. In a typical GDV patient, glucose monitoring every 24 hours is likely more than adequate. I think as a profession we forget or don't pay as much attention to catheter care as we should, and so I just want to remind everyone that peripheral intravenous catheters, should typically be changed every 3 days due to the risk for thrombophlebitis. Central intravenous catheters are typically good for at least 1 week. So in an uncomplicated GDV patient, you likely wouldn't have to worry about changing out a central catheter during that patient's hospitalization. But if things go wrong, there are intraoperative or postoperative complications, and a patient does need to stay in the hospital for more than 7 days, and you have ordered a central line, you will need to consider changing that line after about 1 week. Fluid therapy to support cardiovascular function is just as important in the postoperative period as it was in the preoperative stabilization period. We're typically reaching for isotonic crystalloids, and the type of crystalloid that we reach for is based on your patient's electrolytes and current acid-base status. I tend to stay away from normal saline, 0.9% sodium chloride. And I do that because remember that fluid is a very acidic fluid, pH of 5.5 or 5.6 depending on where it's made,